Hello friends, and welcome to Sterile Field Guide, a podcast dedicated to medical student general surgical education. I'm Alex, and I'll be your guide. Hey friends, welcome to episode 2 of Sterile Field Guide. I'm Alex, I'm a third-year medical student, and we're so happy that you're here. Before we begin, I wanted to let you know that we do have a Patreon account where you can sign up as a supporter for $1 a month if you're able. This podcast is run solely on hospital coffee and your support. You can also sign up for exclusive educational content for $5 a month, where you will get a Patreon exclusive video once a month, as well as access to an exclusive community. Don't worry, this podcast will always be free. Today we're talking about how to pre-round on a patient. If you joined us for our last episode, we talked all about the elements of a SOAP presentation, and that will inform a lot of what you gather from the chart when you're pre-rounding. There are some other things that you'll want to keep in mind or have handy if somebody asks you that you won't talk about in your presentation, and we'll add those elements in this episode. Be sure to check out the Instagram at Sterile Field Guide for additional information, as well as those summary slides just like in the last episode. All right, first let's blast through some explanations. So what is pre-rounding? Pre-rounding is something that you do before rounds to prepare yourself for your morning presentation. This typically occurs an hour or two before you participate in rounds. What do you need to pre-round? I only use a small notebook and my stethoscope, as well as a pen to write stuff down. I write down all of the information that I need for my presentation. I know some attendings will sort of encourage you to get to the place where you could present your patient without notes, and I think that that's totally reasonable, but if you do need to write stuff down to reference in case you forget a lab, that is totally reasonable. You might need special tools to pre-round depending on what service you're on, such as neurosurgery. You may need to bring a pen light or a reflex hammer, etc. with you to do a more in-depth neuro exam, but for most services, especially general, just having your hands, a stethoscope, a notebook, and a pen is probably all that you need. How much time do you need to pre-round on a patient? I would say when you're starting out, you want to give yourself a lot of time to pre-round. I started out coming very, very early to the hospital to give myself plenty of time to chart review, talk to the patient, and then fine-tune my presentation after I'd completed these tasks. I would say when you're starting out, you need probably up to an hour or more for just one or two patients in order to do this well. You will get faster at pre-rounding, but I would encourage you to give yourself plenty of time when you start out, just so that you can see how much time you really need. Because it would be better for you to have extra time than it would for you to be in a rush or not be able to complete all of your tasks. There are a couple of key components to pre-rounding that you should know about. The biggest two are seeing the patient and checking the chart to see what happened overnight. After that, you're mostly just preparing for your presentation and then eventually giving your presentation, which we talked about in the last episode. So we're going to start off talking about things you should do when you're seeing the patient. You can do this in any order. You can chart review and then see the patient, or see the patient and then chart review, whatever works best for your workflow and the way that you learn. I think both of those are extremely valid options. All right, so typically this is occurring in the morning. So key components of your morning interview, you can do this in a systematic way, but there are a couple of things that you'll definitely want to check on. So just going through system, starting with neuro, a big complaint patients typically have is pain. So we always want to check in and see how well their pain is controlled. How are they feeling overall? Are they alert and oriented? Has their mental status changed at all? Some tips about evaluating mental status. If your patient is seemingly disoriented, here are some questions you can ask them. You can ask them where they are. And if your patient is seemingly disoriented, you can ask them some questions, and then there is sort of a stepwise way to ask these questions, and sometimes people don't know. So the first thing you should do is ask them the question. So for example, you can ask them where they are to assess if they're oriented to place. If they're not sure where they are, the next step is to give them a list of options to choose from. This is the next step to see if they're able to pick out from a list where they are. That is a different level of orientation than if they still can't pick it out when you give them a list. So that's an important distinction to make. Some questions you can ask them where they are. A lot of people ask them what day of the week it is, but I sort of shy away from asking what day of the week it is because I hardly know what day it is and I haven't been in the hospital for 3 weeks. So other questions you can ask are Like, what year is it? What month is it? What season is it? Some people ask, who is the president, etc. So those are some orientation questions you can ask if you are concerned your patient is not oriented. The next thing, we're going to skip over respiratory and cardiac because you'll go over that in your physical exam and your review of system, but some more questions you're going to want to ask. Skipping down to FE and GI, a big question that med students are tasked with asking is, did they have a bowel movement? So tracking and making sure that patients are having bowel movements. As we mentioned in the last episode, this can be criteria for discharge and also a way for us to keep track of if this patient has a bowel obstruction or if the surgery we did is causing some sort of ileus. So important to ask. I know it seems like a silly question. Ask it every single day. You can also ask them if they're tolerating their food. If you've recently put them on a diet, tolerating their food is something that we can keep track of. And then if there's any nausea or vomiting, that's something that you want to know. Skipping down to the extremity portion of our questions, you can ask the patient if they've been out of bed, if they're able to, if the orders are in for them to be out of bed as tolerated, if they've been into the chair, walking around, and how often. This is important to just sort of see generally how the patient is doing. And then you can also do a review of systems every time. So this is just sort of like what we talked about in the last episode. I like to do my review of systems just like this. This is how I will ask the patient the questions. I will say, are you having any new headaches, changes in vision or hearing? Are you having any difficulty swallowing? Are you having any shortness of breath, pain in your chest, or feeling like your heart is skipping beats, beating too fast or slow? Do you have an upset stomach? Are you having any nausea or vomiting? Have you noticed any diarrhea or constipation or changes in the color of your stool? Do you have any pain or burning when you pee or changes in the color or smell of your urine? Any new pain or itchiness or rashes that you've noticed? So that's like a review of systems. That's a lot of questions, but you can find an example of a review of systems on the Instagram. The next thing, other things that you want to pay special attention to when you are seeing the patient is if the patient has had surgery, it's important for you to inspect the incision sites or the dressings. One thing to note is as a med student, you probably should not be taking dressings down unless a team specifically asks you to do that. Typically, your team will ask you not to take the dressings down, and sometimes there's a reason why the dressings need to stay on longer. So I would never take a dressing down unless you've received explicit instruction to do so. But ways that you can describe it, if the dressing is in place and you can't see the wound, you can say that the dressing appears clean and dry. If the incision is visible to you, you can comment that it is well appearing. If it appears to be well appearing, you can also comment on any exudates from the incision, if it appears red or indurated, if there's staining of the dressings, if there's copious blood on the dressings, etc. So important to sort of look to see what you've done to the patient and what the results of that are. It's also not a bad idea to know when the dressing should be changed if there are specific reasons for keeping the dressing up. And one example I can think of when a dressing should stay up is with plastic surgery. Sometimes they'll leave their dressings out for a few days with grafts to keep them in place. Some pro tips when you're visiting patients in the morning is to try to turn on a small light when you first walk in instead of turning on the big light all at once. It's not fun to be woken up by bright lights, so it's a good idea to find out where the soft lights are in the hospital room. There's usually one that turns on a tiny light and there's one that turns on the big light. So try to figure out the anatomy of your hospital room before you go turning lights on. If you need to visualize something, you should turn the lights all the way on or use a flashlight on your phone or something else to examine the patient. But I would start out with a soft light before turning on a big light just to spare patients the agony of being woken up at 5 a.m. by a bright light. I would also just say in general, you should leave patients how you found them or better than you found them. And what I mean by this is put their socks back on if you take them off, cover them up, adjust their pillows, turn the lights back off, close the door if they had the door closed, etc. And if you want to go above and beyond, some pro customer service tips for your patients is first you should know where the supply closet is so that you can provide supplies to the patients if necessary. And there are a couple things that are extremely uncomfortable for patients, and two of those things are having a dry mouth and having dry lips. So when your patients are NPO, which means that they can't eat anything or drink anything, they often get dry mouths, they get dry lips, and they're just generally uncomfortable. If your patient is NPO and has a dry mouth, you can check in with your nurse to see if you can give them a mouth swab. And if this is the first time that you've ever used a mouth swab, you can ask to watch the way they use it. It's not complicated, but good to sort of watch someone who knows what they're doing before trying something new. Another thing is if the patient is NPO and has dry lips, you can try getting them a little tube of petroleum jelly if your hospital has this, and you can help them put it on their lips if they have some mobility concerns. You can also use sterile jelly for this, but petroleum jelly is preferred. And by preferred, I mean by me as a person. As a patient, I would want you to put petroleum jelly before ultrasound jelly on my lips. Just make a note of that. Okay. For the physical exam section of when you're seeing a patient, when you're just starting out, it's a good idea to do a full physical exam. And then when you're more experienced and your team trusts you a little bit more, it's okay to do a more focused exam. You should present a focused physical exam, even though you've done this full physical. And then if anybody asks questions about specific maneuvers or something else from the physical exam, have that available. Never lie about something that you did or did not do. So if they say, okay, did you check the jugular venous distension? If you didn't check it, just say, oh no, I didn't check it. Next time I will. Instead of saying, yes, I did. It was 7. Like, don't make things up, because when you go to see the patient and their JVD is 15, like, that's embarrassing and also not safe. So never lie about physical findings. If you didn't do it, just say you didn't do it. You won't get in trouble necessarily. Just make a note to do it next time. Another thing on your physical exam is to always check your lines, tubes, drains, and dressings. Some things to note is like, is the skin around your central line red? Is it not red? Is it warm? If this is covered in a dressing, again, don't take that dressing down, but important to sort of recognize early signs of irritation from tape or infection of the skin around a line, or something a little bit more serious like a line-associated infection. So just keep an eye on your lines. Speaking of tubes and drains, it's also important to note the color of the output of the tube. So for instance, pretty normal output for most things is going to be serosanguinous, which is the color of serous fluid plus blood. There are a lot of different colors that things can be. So for instance, if your patient has an NG tube or a nasogastric tube, it can be bilious, which is dark green. It can be gastric, which is a little bit more yellow. It can be bloody, which is bad. So just note the color of the output of the tubes. For a JP drain, your normal is going to be serosanguinous. Frank blood is usually not going to be awesome. And then a milky color is a bad sign, and you should absolutely let someone know as soon as you find that. If your team's already aware, I guess don't worry about it, but let somebody know if you find that. For a chest tube, again, serosanguinous is normal. Is it frank blood? Is it chylous, like that milky color? Did we accidentally put this in the thoracic duct? That would be bad. Is there an air leak? Your team can show you how to check for an air leak on a chest tube. Those are just things to note. It's important to sort of make sure that the things that you have put in the patient are working, and also that you put them in there for a reason. So let's make sure that we're monitoring what they're doing. Okay, so this goes without saying, probably you already know this from medical school, but when you go in to see a patient, you should do your history part first, your physical part second. Typically, do your review of systems somewhere in there so that you can note any new symptoms. And then after that, or before that, you can do your chart review. We talked in the last episode sort of extremely extensively about all the components of a history and physical that you should present to an attending or a resident team. So if you haven't listened to that episode, just hop on back and check it out. But here's a summary of things that you might think are really important from your chart review. And this is going to be gathering your objective data of that SOAP presentation. So every time you should be gathering the vitals of the patient, ins and outs, monitoring what they've taken in and what they've put out, their labs, new imaging, medications, use of PRN medications, etc. Here are some things to check on, and these sometimes can require a bit of extra digging. This would be like when antibiotics, quote, come off. So if your patient is on antibiotics, they usually have a stop date in the chart, so when those antibiotics are supposed to end. So A lot of times your attending or your residents will want to know when those antibiotics are supposed to stop. So it would be a pro tip for you to sort of pay attention to when patients' medications are expiring. In addition, you should keep track of any outstanding orders that don't have results, or if the patient is scheduled to go to imaging soon. Some other things that can be outstanding that you might have to do some extra digging to check on would be like pathology reports that are pending and microbiology reports that are pending, like blood cultures, urine cultures, wound cultures, etc. And the last step of pre-running on your patient is thinking about your assessment and plan. And this is mostly just a thinking phase. This is not something you're going to find in their chart necessarily, not something that you are going to learn from the patient probably, unless they are also your attending. You should, at this time, take time to think about what the patient's problems are. And if you're not doing a plan by system, this would be the time to rank the problems in order from what needs the most attention to what needs the least attention. For example, a new pneumonia might need more attention than well-controlled asthma or a stubbed pinky toe, so you should talk about pneumonia first in your presentation. And then for the plan section of this, I would again encourage you to make a plan for every problem. Practice making a plan for every patient, for every problem that they have, even if it's a simple medication change, or I want to consult this team, or maybe we should get this lab or this imaging, and it is totally okay to be wrong. And also, it's absolutely reasonable to run your plan by your residents before you present it to your attending. And I think they will be impressed, or at least notice that you are trying to learn and figure out what it means to practice independently and come up with these plans on your own behalf. And that's a pretty solid intro into how to pre-run on a patient or two. You will get faster at this and less likely to miss things as you get more practice, but there can be a lot to think about in the beginning. I hope this was helpful for you, and now I hope that you have a framework for what pre-running looks like and how you can approach it independently. Again, there are summary slides from this episode on the Instagram at Sterile Field Guide. I hope that you enjoy them, and thank you so much for being here. That's it for today's podcast. You can support this podcast and receive exclusive educational content on Patreon, and find us on Instagram at Sterile Field Guide. Questions and requests can be submitted to our Gmail at sterilefieldguide@gmail.com. Thank you for listening, and until next time, may your retraction be superb and your suture tails be the perfect length.